Sam? In our remarks, we don't refer to the expense.
Hey, everybody. Thank you for being here. I'll have some brief remarks and then have my colleagues, and then we'll open up the floor for questions. Today, we're unveiling legislation that we have been working on for 2 years. And it is improving coverage for a group of folks who are covered by both Medicare and Medicaid. And so because they are dually eligible, they are called duals. Now, this is one of those issues that perhaps you've never heard of, but incredibly important. If you speak of duals, they cost almost twice as much as the average Medicare patient, but their outcomes are far worse. So on average, a dual eligible will die 15 years earlier than a non-dual eligible patient. So we're spending more money and we're getting worse outcomes. I ran into this problem when I used to work in a hospital for the uninsured. And so, as you might, are the poorly insured. And so we just saw lots of duals. And there are just a lot of issues. There's a reason why they don't live as long. One, they're sicker, but two, there's a lot of issues. But three, to coordinate Medicare and Medicaid, to actually get those programs to work together as opposed to merely attempt to push the cost upon the other is incredibly difficult. So we've been working on a solution where we actually make it easier for the patient. We align the incentives for the health plans to work together as opposed to merely push the cost and responsibility upon the other. So we think we've found the sweet spot. We've come up with something which we think will better coordinate care, therefore improve outcomes, but save the taxpayer money. Because ultimately you've got to have a sustainable system if the system is going to work. It's a new framework working on issues which actually kind of boils down to one thing, a lack of coordination. We think with that, we can accomplish the goals we put out. I'm very excited to have my colleagues up here. It's something which is what the Senate should be doing. It takes us years to get it done, but it's incredibly important to the American people, building upon past experience to figure out how to better go forward to benefit fellow Americans. With that, I'll turn it over to Senator Tom Carper.
Thank you, Dr. Cassidy. Good afternoon, everybody. Bill Cassidy and I normally get together on Thursday afternoons right about this time. And we do it on this floor, just down the hall. We meet with Democrats and Republicans. We meet with a guy named Barry Black, who's the chaplain for the Senate, and we have a Bible study. And the reason why I mention that today is because one of the takeaways from us every Thursday from that Bible study is that we have a moral obligation to the least of these. When I was hungry, did you feed me? When I was naked, did you clothe me? When I was sick and in prison, did you visit me? When I was a stranger in your land, did you welcome me? When I needed health care, did you help provide it? Did you do it in a way that was cost effective, that made sense and was simple and easily obtained? And we have a moral obligation to do all of those things. And we have a moral obligation to make sure that the two wonderful programs, Medicaid and Medicare, work better on behalf of the people who need them and who use them. My colleagues hear me say, my staff hears me say a lot, find out what works and do more of that. And another one of my favorite sayings is, everything I do, I know I can do better. Everything we do here, we know we can do better. Our parties don't have a block on all the great wisdom. We find out when we work together, we do better. Bipartisan solutions are lasting solutions. It's bipartisan solutions, and I think it's a solution that's going to help a whole lot of people, not just in the next several years, but for a long, long time to become. I want to thank Senator Cassidy for letting me be his partner in leading the duals working group. I also want to thank the members of our group. Some of you are here and others will be arriving. I want to thank our staff. If you're a staff member, you've worked on this, raise your hands, please. No one wants to admit to. Yes, you do. Thank you. Done great work. Thank you for that. We received, I think, I want to say hundreds of letters, at least 100 letters, maybe more. Feedback from the early discussion of this legislation as we share with the world what we come up with. As Dr. Cassidy has just shared, beneficiaries who are dually eligible for both Medicaid and Medicare are oftentimes the sickest and most vulnerable patients in our country. And when I was state treasurer and trying to get my hands and my head around healthcare delivery and later on as governor, one of the things I learned was that some of the sickest people, most expensive people to take care of are those who are both in Medicaid and in Medicare. They oftentimes get overlooked in healthcare reform, but not today. Our bipartisan legislation will reduce many of the complexities of our health care system for this particular population. And currently, the system of care for dual eligible beneficiaries, it's in a word disjointed. It's not a word you hear a lot, but it's in a word it's disjointed. Medicare and Medicaid have little to no coordination when it comes to patients who are enrolled in both programs. And that makes providing resources and caring for dual eligible difficult, real difficult. I'm going to tell a quick story about a woman, not in Delaware, but a woman in New York State, I think in New York City. Her name is Salima, and she had a debilitating spinal cord disease that required her to use a wheelchair. We have a lot of people in wheelchairs these days, but after the wheelchair she had been using broke down, she needed a new one. And as a dual eligible, Salima could not figure out the complex nature of Medicaid and Medicare on her own in order to get approval of her claim for a new wheelchair. She ultimately had to enlist a third-party organization for help. Ultimately, it took not weeks, not months, it took a year and a half. It took a year and a half for Salima and the organization to figure out whether Medicaid or Medicare would be the one to approve her claim, during which she was restricted from living independently. That's not acceptable. That's unacceptable. And we can do better than that. And we need to do better than that. Medicaid and Medicare cannot continue to operate in silos. And at long last, our legislation, I think, begins to change that by developing a brand new program specifically dedicated to providing comprehensive, integrated health care for dual eligible beneficiaries. Patients and providers alike will experience the benefits. It will lead to better healthcare outcomes for patients like Salima. There's a lot of them. It will reduce administrative barriers, and it will result in significant cost savings for patients, for government, for American taxpayers. Again, find out what works, do more of that. And with that, I think I should turn to John Cornyn for his comments. John, come right in here, buddy.
Tom. Well, the problem that has been described to you that this bill will fix leads a lot of people to wonder, is the federal government stuck on stupid? I mean, the fact is taxpayers are funding both Medicare and Medicaid and wasting a lot of money in the meantime. And as Dr. Cassidy pointed out, we can actually improve outcomes. That means healthier people, healthier, more productive people, increase their lifespan if we coordinate that care. So to me, this is just unbelievably dumb, the status quo. And as you pointed out, Dr. Cassidy, this makes enormous sense, coordinating that health care. Right now, I think the federal government spends roughly, I want to say 18, 19, 20% of GDP on health care. That is multiples of any other developed country around the world. And this is one reason why we spend so much money, because frankly, a lot of it is wasted by a lack of coordination between these two important programs that more than 700,000 Texans depend on. Those who are jointly enrolled in Medicare and Medicaid. So I want to thank all my colleagues and Senator Cassidy's leadership for bringing us here today. This is long overdue, and I'm pleased and proud to join all of them in solving this problem, which unfortunately should have been solved a long time ago. Thanks.
Well, thank you, Senator Cornyn, for that gracious introduction. And now, you know, echo what John said. Yeah, we have been stuck on stupid for a long time on this. What got me really interested was my time as governor. We were seeing expansion of our Medicaid population. We had this category of folks who qualified for both Medicaid and Medicare. And I think any of us involved in government could tell, the way Tom did, you know, countless stories of this mismatch. I think on our cheat sheet here, the numbers, these are the sickest people. I think duals make up about 19% of the Medicare population, but they account for about 34% of the Medicare spend. In Medicaid, duals make up about 14% of the total enrollment, but they make up 30% of the total spend. So if we can get a better coordination, if we can actually force states into choosing, working with CMS, a pre-approved plan that will coordinate this, we're going to make great progress. And I've been involved in lots of these bipartisan efforts. I think at the end of the day, what's valuable about a bipartisan effort is, I don't want to make headline news right away, but Congress rarely gets it 100% right the first time they do anything. So if we've got bipartisan efforts, it means, we're going to do what we get right, but also if we don't get it fully right, we both have to own how we come back. And this is a bit of a nerdy technical issue, but it is one that is long overdue. Again, I'll echo John Cornyn's statement. We at the federal government have been stuck on stupid for way too long on this, and I think this approach and coordination is long overdue. And I also want to echo what everybody has said. I guess in this case we're calling you Dr. Cassidy as opposed to Senator Cassidy. I'm not a doctor, but I stayed at Holiday Inn Select last night, so I can act like one. Isn't that a joke? That wasn't a joke? You guys are not rolling the aisles after that? I mean, he said motel, whatever it is. But Bill Cassidy has been the leader of this group. We're going to get it done. I appreciate his leadership, and I appreciate my colleagues' bipartisan support. And with that, I want to turn it over to Senator Menendez from New Jersey.
Well, thank you. And I am pleased to join a bipartisan effort of 6 members of the Senate Finance Committee. And I focus on that because a lot of what we get to do in the Senate Finance Committee is health care. So when 6 bipartisan senators from the Senate Finance Committee come together around an idea, I think it has a real engine of possibility of making it happen. And I want to join my colleagues in recognizing Senator Cassidy, who I work with on so many different issues, and appreciate his particular knowledge here. 12 million people. That's what we're talking about of this group. Over 250,000 in New Jersey who are dual eligibles. It's a huge universe of people to put a human face on it. And these are people who have low incomes. They're either also disabled or over 65, and some of them check off all 3 of those boxes. These individuals are forced to navigate both of the country's 2 largest public health insurance programs, Medicare and Medicaid, to get the care that they need. It can be a daunting, overwhelming effort for the beneficiary, and an inefficient, as has been pointed out, an expensive one for the federal government. Both programs play crucial and different roles for this population. Medicare pays for urgent medical needs like surgeries or hospital stays. Medicaid supports long-term services like home visits. But for these uniquely vulnerable populations, there's too much of a gray area, which means that some of the country's sickest, poorest, and most costly patients are often stuck navigating a complicated healthcare maze. Imagine if you're in your late 50s and you suffer from a condition, as Senator Carper suggested, that limits your mobility. With your low income and disability, you qualify for both Medicare and Medicaid, but getting the help to be able to make you mobile again, a fulfilled member of our society, can be an impossibility. This is a reality for far too many Americans. It doesn't take a PhD in public health or economics to realize the current status quo is unacceptable. So to tackle these challenges, we did something that Congress doesn't always do. We set out to listen to healthcare and patient communities. We introduced this legislation informed by an extensive feedback from over 125 stakeholders. Our legislation gleans from them the ability to improve coverage for dual eligibles by mandating that each state, with CMS support, develop and implement a comprehensive, integrated health care plan for dual eligible beneficiaries. These plans streamline care coordination. They assign a care coordinator for each beneficiary, almost a navigator in the process. And furthermore, the legislation addresses confusion by reducing look-alike plans that ultimately appeal to this universe, but doesn't do right by them, in my view. It streamlines the appeals process, and it curbs third-party marketing organization incentives. And finally, it expands PACE coverage, allowing for enrollment anytime and extending eligibility to those under 55. This bill is about making sure that we take care of the quality of health of those 12 million Americans, that we save the federal government money at the same time that we maximize their ability to fulfill their God-given potential. And I think that speaks a lot about what you talk about every Thursday. Thank you very much. And I'll turn it back to Senator Cassidy for questions.
Thank you all. I've been asked by TikTok and TikTok and TikTok. So I'm going to ask everybody to kind of limit their discussions to duels. And if you want to talk to us about something else, grab us on the way out.
Clock is ticking, though.
The TikTok is ticking. Yes, ma'am.
Thank you, Senator Cassidy. So what is the next step for this legislation? Are you going to ask Senator Sanders if you can mark it up, or are you going to ask the Finance Committee if you can mark it up? And then also, have you talked to the House? Do you have House members that are interested in a companion legislation there?
You want us to talk about the Senate Finance Committee?
As it turns out, there's and I'm not running for re-election. I've encouraged a woman who used to be an intern in my office when I was in the House and then a member of our staff. And later when I was governor, she became our Deputy Secretary of Health and Social Services. She serves on the Energy and Commerce Committee, which has broad jurisdiction, including on a number of healthcare issues. Her name is Lisa Blunt Rochester. And later this afternoon, Congresswoman Lisa Blunt Rochester will receive a phone call from her old friend, Tom Carper, and to give her the lowdown on what we've come up with here in the Senate, and to say we're looking for not just a few Democrats and Republicans in the House, but those that know something about healthcare issues, or on relevant committees that deal with healthcare issues. She would be one of the first people that I think I'd like to get involved. So Joe Biden likes to say all politics is personal, and that's true. And we're going to use some of his personal relationships to try to get this party started over in the House of Representatives.
And aren't we looking for the same kind of vote out of the Energy and Commerce Committee that the TikTok bill got?
Yes.
15-0.
But we've discussed this with our chair and ranking member on Senate Finance. They understand this is a huge issue with poor outcomes and high cost, and they are interested in pursuing this. I can't tell you, we do not have a hearing scheduled, but I think that there will be an interest in this. Yes, sir. Well, these guys can never talk about the ACA failing, so I'll take that one. We actually built upon that experience. One thing that happened is that, say, the state of California would automatically enroll a dual eligible in a Medicaid plan, and states can do that on Medicaid. But they would do it kind of randomly, and it would separate the patient from her primary care physician. So, boom, she would get out and go back to where her primary care physician was. In this, we say you can only enroll somebody in a plan if his or her primary care physician is in that plan network. So we're preserving that relationship. Secondly, there were some in that plan. By the way, I applaud the ACA for attempting to get this. And like I say, we are building off of that learned experience. There's also an incentive for brokers to churn between plans because they received a commission per placement. So you're in a plan, get a commission, place them in another, get a commission, place them in a third, you get a commission. Here, we say it has to be an independent broker, and there's only going to be one commission given. So if somebody's in a plan and moves to another, if they're automatically assigned, no commission, but they're moved to another, there's a commission, you're not going to continue to churn. There's going to be only one person, only one time for that. So we think we kind of addressed two things that we at least two things that we recognized as hamstringing the success of that program.
This is an area where the ACA had the right aspiration, but it didn't meet the goal. And now we've got years of experience, and this group has been quietly working on this for about a year, had all of this input, and this is the kind of bipartisan fix that is needed to take on a problem that, again, I dealt with as a governor 20 years ago.
And I want to emphasize one thing that these two men mentioned. We put out an RFI, right? And we got how many responses?
125.
125. This is from people who had experienced that effort. who had experienced other efforts. And we received that, and we attempted to incorporate their input to refine our product. So we very much are building upon the learned lessons. Anyone else?
Thank you.
Thank you.
Pray for us.
Yeah. Thank you,
All
my
right,
friend.
pal. Good work.
See you in a minute.
Okay. You bet.